the role of anticoagulants in the next few minutes. These are my disclosures, and I have been involved in some guideline committees, but not in relation to atrial fibrillation, and I was co-chair of the ROCKET-AF trial. So what about the issue of untreated and undertreated patients? If we're to really define where the problem is, in my view, it was set out beautifully in one of Lord Kakar's slides, showing you the proportion of people that remain untreated with atrial fibrillation. Even more challenging is the information that there is treatment of some of those at CHADS VASC 0 with anticoagulation, and conversely, some of those with higher CHADS VASC risk without. So our challenge is to anticoagulate those at stroke risk, provided that they don't have excess bleeding risk, to improve adherence to anticoagulation, and to be very clear about the message that aspirin is not an adequate therapy for stroke prevention of atrial fibrillation. Now, you'll be familiar with the concepts behind this slide. What is the lowest effective intensity for warfarin therapy? And you can see that for INRs below 2, there is a progressive rise in the odds ratio for stroke. So maintaining this level seems to be ideal, but in practice, much more challenging. Conversely, as the INR rises, so there is a rise of intracranial hemorrhage. And we've got to recognize that intracranial hemorrhage rises with the INR, but overall, many of the people who suffer major bleeds and intracranial hemorrhage on vitamin K antagonists are actually in the therapeutic range. So, I made the statement that we should replace warfarin, we should replace aspirin with an anticoagulant. Why? I show you here the summation of all of the aspirin trials, and below that, all the antiplatelet trials. This is the head-to-head comparison of warfarin versus antiplatelet. And what you can see is here's the line of identity. And the confidence bounds are clearly well away from the line of identity in favor of anticoagulation, both in the aspirin trials and in the trials of all antiplatelet agents. So if somebody tells you, well, my general practitioners are using aspirin because it's nearly as good, the answer is no. And there is, we don't have time to go into it, evidence that also aspirin is not necessarily safer. Where are the problems with vitamin K-based oral anticoagulation? First, there is an understandable concern about the risk of bleeding and the contraindications. We've talked about the narrow therapeutic window, the need for frequent blood testing, the extent of drug interactions, discontinuation for surgical procedures and for other events that are at risk of bleeding, and lifestyle restrictions. So these are clear constraints. In our country, we have an expression between a rock and a hard place. I don't think I would like to be perched on this rock, but it's to try and symbolize, on the one hand, we have stroke risk, and the other bleeding risk. It's a very long way down to the fjord below. Finding the right balance is key. Now, we know that our Dutch colleagues are very good at this. Our Dutch colleagues have been advocates of anticoagulation for a long time, and they are probably better than most people at anticoagulation. But even our Dutch colleagues do not get conventional vitamin K-based antagonism, anticoagulation in the therapeutic range all of the time. It is still a challenge. So you might think that once we've, as Dan Attar said, we've identified the first step, is this patient at risk of stroke? And Dan has shown you very clearly how that can be done. And you then think the next stage, let's follow the guidelines, let's anticoagulate. Next question is, how well are people maintained on anticoagulation after being started? And these are data from Elaine Heilich in North America, and they are observational data on the tolerability of warfarin during the first year of therapy in elderly patients. And indeed, most of our patients are elderly. And what's the take-home message? Only 58% of the time in the therapeutic range. Rates of hemorrhage, major hemorrhage, 7.2%, intracranial hemorrhage, 2.5%. And these rates substantially higher in those 80 years or more of age. Overall, 28% of patients had discontinued warfarin at a year. And what's even more concerning is even using the old-fashioned CHADS-2 score that was available then, those at high stroke risk are much more likely to be taken off therapy. So there's a double-edged sword. As the risks go up of both bleeding and stroke, people are more likely to be discontinued on a vitamin K antagonist. Lord Kakar has very clearly outlined some of the fascinating international data in some of the early slides about the use of anticoagulation. I think it's very important in all of our countries that we have comprehensive data, if possible, and reference data. So let me give you an illustration. This is what's called the Dawn benchmarking system, and it means that each individual center here can reference their data to the entire data set. This is not small. These are 2 million INRs, principally through primary care practitioner settings in our country in the UK. And this particular center, you can see that their performance was slightly worse than the median. Nevertheless, overall, you can see the time in therapeutic range is around 70%, which is quite reasonable. Not as good as some of our Scandinavian and Dutch colleagues, but quite reasonable. So what about the targets for anticoagulants? We know that they're the parenteral ones on this side, and we're concerned now with the oral ones. Obviously, they're the anti-10As and they're the direct anti-2As. I'm not going to go into detail in the individual studies, and we must remember, above all, that the trial populations differ in characteristics and in design. Nevertheless, to be provocative, there are more similarities than differences in outcome. Look at stroke and systemic embolism, 0.65 in terms of the hazard ratio, 0.79, 0.79, 0.79. The death rates, the intracranial hemorrhage rates, and the trial group sizes. So overall, I think that the newer anticoagulants represent an important advance. And we must come to the guidelines. These are the 2012 guidelines. And you can see that the, for a CHADS-2 VASC of 2 or more, vitamin K or oral anticoagulants are 1A recommended. And in the text, vitamin K antagonists are not preferred to the novel anticoagulants. They are the preferred ones in the text. So based on the evidence, what's the future? Systematic detection of atrial fibrillation and stroke risk, improved patient education for compliance, good quality registry programs like GARFIELD and quality control, reducing stroke risk and complications, the advantage of not routinely having to attend INR clinics, antidotes rarely, and looking at new indications. And in my view, these will become the norm in the future as they are becoming steadily now. Thank you very much.